Hey everyone. You know, childbirth is this incredibly profound, natural process. But what happens when it hits a snag? Well, that's when this whole other world of amazing, hands-on medical skills comes into play. Today, we're going to pull back the curtain on the critical maneuvers that doctors and midwives use to ensure a safe delivery when things don't go exactly to plan. And that's really the big question we're tackling today. When a complication pops up, there's this incredible toolkit of techniques, fine-tuned over decades, that gets deployed with just amazing precision and speed. These are the obstetric maneuvers that protect both mom and baby, and we are going to break down exactly how they work.
So here's our game plan. We'll start with the critical moments that call for an intervention. Then we'll dive deep into the specific moves for big challenges like a breech birth and something called shoulder dystocia. We're also going to see how doctors can actually map out a baby's position from the outside, and we'll wrap up with a few other key techniques. All right, so while the vast majority of births happen totally fine on their own, medical teams are always trained for those moments that demand their expertise. They have this whole toolkit of physical techniques ready to go at a moment's notice to guide a delivery to a safe conclusion. Okay, first up, let's talk about a big one, the breech birth. This is when a baby is lined up to come out feet first or bottom first, instead of the usual head first way. And as you can imagine, that requires a very specific set of skills to manage safely. So what is a breech delivery really? It's exactly what it sounds like. The baby is set to exit the pelvis with their little butt or feet leading the way. This completely changes the whole dynamic of birth, mainly because the biggest part of the baby, the head, is now coming out last. So how do they handle it? Well, they've got this dedicated toolkit. And these aren't just random moves. They're a sequence of maneuvers, each designed for a specific stage of delivering a breech baby. Let's start at the beginning. First on the list is the Pinard maneuver. The whole goal here is to get a hold of the baby's feet. The doctor or midwife applies pressure in a very specific spot, right behind the baby's knee. This encourages the leg to bend, which then allows them to gently deliver one leg and then the other. Okay, so once the legs and body are out, the game shifts to the shoulders and the head. This is where Norcet's maneuver comes in. It's a really careful rotation of the baby's body to free up the shoulders one at a time. After that, the Burns-Marshall maneuver helps guide the head out in this smooth, controlled arc, bringing the delivery to a safe end. And because no two births are the same, there are always backup plans. The Mariso maneuver is another way to help flex the baby's head to guide it out. And then there's the Prague maneuver, which is for the very rare case where the baby's back is facing the wrong way. It just goes to show how many tools they have for every possible scenario. Now, let's switch gears to another scenario. And this one can be a true time is of the essence medical emergency, shoulder dystocia.
So what's actually happening here? Picture this. The baby's head is delivered, but then bing stop. One of the baby's shoulders gets caught behind the mother's pubic bone. It's a purely mechanical problem, and it needs an immediate mechanical solution.
And for this, there's a protocol. This isn't just a list of suggestions. It's a rapid-fire escalation of interventions. The medical team will literally run through these maneuvers, starting with the least invasive until that shoulder is free. So the first thing I'll almost always try is the McRoberts maneuver. It's brilliant in its simplicity. By pulling the mother's thighs way up toward her abdomen, it actually tilts the pelvis and opens it up just a little bit. And often, that tiny change in geometry is all it takes to create enough space for the shoulder to slip right through. It's non-invasive and amazingly effective. But if McRoberts doesn't do the trick, they move on to a rotational technique. And the name of this one pretty much tells you everything you need to know, the wood screw maneuver. A practitioner literally reaches inside and carefully rotates the baby's shoulders to sort of unscrew them from that stuck position. Then you've got the Rubin maneuvers, which are two sides of the same coin. Rubin 1 is external. Pressure is applied on the mother's belly to try and nudge the baby's shoulder free. If that doesn't work, Rubin 2 is internal, where the practitioner goes inside to push directly on the back of the shoulder to get it to move. When other things aren't working, there's the Gaskin maneuver, which involves moving the mother onto her hands and knees to let gravity help out. And then, in the absolute most extreme and thankfully rare situations, there is the Zavanelli maneuver, a true last resort procedure to resolve this incredibly critical emergency. Okay, so far, everything we've talked about is reactive. It's what to do when something goes wrong. But what about getting ahead of the problem? That is where the Leopold maneuvers come in. This isn't about fixing an issue. It's about figuring out the lay of the land before labor really gets going. This is this really cool systematic 4-step check. Step 1 is the fundal grip. where they feel the top of the uterus to see what part of the baby is up there. Is it the head or the butt? Step 2, the lateral grip, is about finding the baby's back on one side and all the little hands and feet on the other. Third is Pollock's grip, to check what part is sitting right above the pelvis. And finally, step 4 assesses how low the baby has dropped into the pelvis.
And really, this is the perfect way to think about it. It is literally diagnostic medicine at its most fundamental level, just using skilled hands to create a map, to gather all this critical information that helps shape the entire birth plan. It's amazing.
All right, to round things out, let's just quickly touch on a couple of other key maneuvers that are used in very specific but very important situations.
First, you have the Richmond maneuver. This is all about finesse and control. It's a technique to help ease the baby's head out very slowly and gently to prevent tearing. Then there's the Derson maneuver. This is used in some really rare emergencies, like a breech birth, where the cervix just won't dilate all the way. It involves making tiny, precise incisions to open the way for the baby to be delivered safely.
And believe it or not, we've only just scratched the surface here. There are over 20 distinct obstetrician maneuvers out there, probably many more depending on how you count. It's just a vast, incredible field of hands-on medical expertise. So if there's one thing to take away from all this, it's that every single one of these maneuvers is a testament to a deep, deep understanding of anatomy, of physics, and of the human body. It's pure skill and compassionate care put into direct action when it matters most. And that really leaves you with a final, kind of amazing thought. In our world of high-tech scans and machines, these hands-on skills almost feel like an art form. How does this blend of pure science and practiced physical skill change how we think about what it really means to be a doctor? Something to think about. Thanks for joining me for this explainer.